All right, let's dive into one of the most important and high stakes topics we face as medical professionals: non accidental injury. Getting this right isn't just about a gut feeling, it requires a systematic, evidence based approach. And that's exactly what we're going to break down today. To really understand why this is so critical, let's start with just one number: 81.6%. So, what does that number mean? Well, it's pretty sobering. A long term study in the Journal of Pediatric Surgery found that 81.6% of young kids who survive abusive head trauma are living with a significant disability by the time they're 11. Just think about that for a second. The impact isn't just the initial injury, it's a ripple effect that can last a lifetime. And as this quote from StatPearls points out, sometimes the consequences are even more severe. For children under 2, abusive head trauma is a leading cause of traumatic death. So the stakes in getting this diagnosis right, they honestly couldn't be higher. Okay, so with the stakes that high, how do we even begin to identify these vulnerable children? Well, it all starts with the history. It's about maintaining a high index of suspicion from the very first moment you meet the patient and their caregivers. Whether you're in a Viva exam or dealing with a real-life case in the ED, the history is your number one tool. Your job is to listen, really listen, not just for what is being said, but just as importantly, for what's not being said. So what are those classic red flags we should be listening for? Ask yourself, is the story changing? Maybe one caregiver tells you one thing and the other tells you something different. Does the explanation even make sense for the child's age? Can a 6-month-old really get a complex skull fracture from just rolling off the sofa? An unexplained delay in seeking help or a flat-out denial of any injury when it's staring you in the face, these should set off major alarm bells. Now, this is a really important point. Social risk factors like these are not a diagnosis. Just because they're present doesn't automatically mean abuse has happened. But what they do mean is that the possibility is higher, and they should absolutely lower your threshold for a much more thorough evaluation. Okay, so we've taken the history. Now we move on to the physical examination. This is where we hunt for the objective, specific signs of an inflicted injury. And let me be clear, this has to be a complete top-to-toe assessment with the child fully undressed. No shortcuts. Bruising is by far the most common injury we see in physical abuse. But we all know that toddlers are little bruise magnets, right? So the critical question is, how do you distinguish a normal toddler tumble bruise from something much, much more sinister? The answer is all about the location and the pattern. And thankfully, we've got some great evidence-based tools to help us here. The 10 for face scar clinical decision rule is one you should absolutely commit to memory. Remember the key phrases. 10. That's bruising on the torso, ears, or neck in a kid under 4. And critically, any bruise anywhere on a baby under 4 months old is a major red flag. There's a saying for a reason: those who don't cruise shouldn't bruise. But it's not just where the bruise is, right? It's about what it looks like. Look for bruises on soft, protected areas like the back or the buttocks. Are there clusters of bruises or patterns that literally look like the imprint of a belt or a cord? And check out this stat from a 2002 study. Over half of abused kids had a bruise with a clear, identifiable shape. That's a story written right there on the skin. Fractures are the next huge area, and this slide really highlights the difference. We all know the common accidental injuries: toddlers' fractures, broken collarbones. We see them all the time. But when you see fractures in that other column, posterior rib fractures from squeezing, or those classic metaphyseal corner fractures from shaking a limb, your suspicion has to go through the roof. These are what we call highly specific injuries. They are rarely, if ever, accidental. And please remember this clinical pearl. It can be easy to get falsely reassured if you don't see a bruise over a fracture. But the RCPCH evidence review is clear. One study showed 58% of abusive fractures had no bruising nearby. So the absence of a bruise means absolutely nothing. It does not rule out an inflicted fracture. Finally, and this is an area that can easily be missed, you absolutely have to look in the mouth. An injury here, especially a torn upper labial frontum, that little piece of skin connecting the lip to the gum, can be a crucial, sentinel injury. It might seem minor, but it can be the very first warning sign that something bigger and more dangerous is going on. Okay, so your suspicion is high. You've got red flags from the history, and you've seen concerning signs on your exam. What's next? Now we have to proceed to a structured investigation pathway. The whole point here is to find any other injuries that might be hidden under the surface. And you don't have to guess what to do. The Royal College of Radiologists gives us very clear evidence-based guidelines. For any child under 1 with suspected physical abuse, it's a full skeletal survey and a CT head, mandatory. Between 1 and 2, it's a skeletal survey with a CT for specific indications. And please, do not forget that critical follow-up survey at 11 to 14 days. It is essential for catching those subtle healing fractures you might have missed the first time around. Here's a high-yield detail for you. When you order a skeletal survey, you need to know what you're asking for. For the chest, standard AP and oblique views are required. So why the obliques? Because they are absolutely essential for properly visualizing the posterior rib arcs. That's a classic location for inflicted fractures from squeezing, and you can easily miss them on an AP view alone. It's a crucial detail. So, you've done your due diligence, now what? Well, this brings us to the final and arguably most important part, your action plan. This is where your clinical decisions directly protect the child from further harm. First things first, before anything else, you treat the child in front of you. Regardless of what you suspect caused the injury, your immediate priority is clinical stabilization. And that means you follow the structured approach from Advanced Trauma Life Support, or ATLS. You know the drill. You run through your ABCDEs. It's the absolute backbone of all trauma care, and it ensures you identify and treat any life-threatening injuries immediately. Here's the bottom line. Once you suspect a non-accidental injury, these actions are not optional. They are your professional and legal duty. You escalate to a senior, you consult the safeguarding team, you document every single finding and conversation meticulously, and you make the official referral. You are a vital, indispensable link in the chain of protection for that child. Look, recognizing non-accidental injury is one of the hardest things we do in medicine. There's no doubt about it. It takes vigilance, it takes the knowledge we've talked about today, and frankly, it takes courage to act on your suspicion. The real takeaway here is a question you have to ask yourself. Are you prepared to be the voice for a child who doesn't have one?